Hello, this is Jason Rosenfeld, and welcome to the Introduction to Water, Sanitation, and Hygiene, what I view as essential foundations for health and development. During this presentation, we're going to define a new term, WASH. This stands for Water, Sanitation, and Hygiene, and I'll be using this term from this point forward. So the outline for this presentation is we'll begin with what WASH is, what it includes, as well as a brief history of WASH issues. We'll then go into a review of the current status of the main WASH indicators that were created to help measure progress towards the Millennium Development Goals. Then we will explore the variable impact of WASH on health and development, and we'll wrap up our discussion by looking at a few different models of interventions and programs that are commonly used in WASH programming. Before we continue, it's important to establish a few acronyms and common language that we'll be using during this presentation. I think everyone is familiar with acute respiratory illnesses. Community health clubs is a model that I'll reference towards the end of the presentation, but I'll be giving a more detailed presentation on in class. Community-led total sanitation is a model that I'll be referencing later on. The JMP, or Joint Monitoring Program, is a WHO-UNICEF collaboration that was developed to help develop and monitor WASH indicators that will help us to understand the MDGs and our achievement of those goals. FAST, again, I'll reference later on, is Participatory Hygiene and Sanitation Transformation. It is a model of participatory education and behavior change that is the foundation of most models used today. SWASH is School, Water, Sanitation, and Hygiene, and finally WASH we have already established. So what is WASH? As I already defined, WASH stands for Water, Sanitation, and Hygiene. Within each of these three areas, there are complementary characteristics or aspects that must be considered to ensure good health. For example, with regards to water, we have to think about access to improved or clean water. For example, is a clean water source present? How far away is that source? What is the source's capacity to serve the population it is designed for? And is it seasonally available, etc.? So we have to consider water quality, quantity, and distance as part of access. But another key component of access is the operation and maintenance of that source. As you know, many sources require an operator and some level of maintenance. So for a second, think about the water that comes out of your tap. There are many people, processes, and logistics behind that water appearing every time you turn on the faucet. And these include water treatment, repairmen, etc. So almost all water sources require some degree of operation and maintenance to keep them running so that water remains available. Finally, there are a number of water behaviors that contaminate or maintain water safety. These include the containers that we use to store or to collect water if water is not available in the household, as well as making sure that those storage containers are clean, well sealed, etc. There is also some behaviors around taking the stored water for drinking to avoid contamination, as well as what we call point of use water treatment, actually treating the water once you bring it to the household. So when we look at sanitation, the same three factors are present, but they're slightly different. So when we think about access, we're thinking about what type of sanitation facility, if any, do households have access to, keeping in mind that our goal is to remove feces from the environment. Do people have toilets? Do they have latrines? If so, what types of latrines, etc.? So just like water, those facilities have to be maintained so that they remain in use and continue to keep feces out of the environment. So if we think about comparing private facilities to communal facilities, as well as for the model for how the facility was built or provided, there are significant differences in how those facilities are operated and maintained that we have to consider. So if we look at a communal facility, who cleans the facility? Who repairs it if it's broken? Who technically owns the latrine? Those are different issues if it's a privately owned toilet. There's also defecation behaviors. So, do we keep a lid over the hole of our latrine? Do we keep our facility clean of feces and urine? Where are the facilitators sited within the compound or community? Because we have to make sure that we avoid contamination of groundwater in the environment. So if we dig our latrine too close to a water source, that's a problem. And finally, what do people do if they don't have access to a facility? Do they openly defecate? Do they bury their feces? All of these ultimately impact our health. So finally, there's hygiene, which for some is always looked at as separate from water and sanitation, despite all of the direct links. So for people to be hygienic, they must first have access to hygiene materials, which include water and soap. But then we also have to have behaviors which typically focus on hand washing at key times to avoid diarrhea. But in my experience, I believe that hygiene behaviors in water sanitation go well beyond just hand washing to include face washing, wearing of shoes, bathing, washing our clothes, and food hygiene. So in short, there are a lot of aspects to wash that we have to be aware of. Okay, so buckle up for a very quick history of wash, and here we go. Before the 19th century, many diseases like the plague and cholera were attributed to bad air that originated from rotting organic material. Then, with the help of John Snow and others, the germ theory of disease became widely accepted in the 19th century. As I'm sure you'll remember, Snow is known as the father of epidemiology for his research into the London cholera outbreak in 1854. After meticulous mapping of disease incidents, he noticed that the burden of disease clustered in one neighborhood around a particular water pump on Broad Street. After taking the handle off the pump, the incidence of cholera dropped, and he was able to build his case about water being the primary route of transmission of cholera. Thereafter, the germ theory of disease was promoted by various scientists of the time and then became widely accepted. With this came modern water and sanitation. The practices of dumping garbage and chamber pots into the street was stopped, and sewage systems and plumbing became the norm. Systems for protecting water from contamination were also adopted. However, as European and North American countries instituted and expanded upon modern water and sanitation systems, most colonized countries in the global south continued operating with pre-modern water and sanitation systems, which lead us then to the modern age. So up until the 2000s, many organizations were involved in addressing gaps in water and sanitation through direct service delivery. However, the proportion of the global population still without access to safe water and improved sanitation remained constant. Unlike other health and development priorities, water and sanitation remained unrecognized and secondary to other initiatives. It wasn't until the year 2000, when the MDGs were established, that WASH was recognized as a global priority. Then, in 2002, the UN adopted the statement that water is indispensable for human dignity and is a prerequisite for the realization of human rights. Finally, recognition of the value and importance of WASH. And then in 2010, the UN General Assembly explicitly recognized that water and sanitation are human rights. So we've already discussed the MDGs in other class meetings and lectures, but for today, let's focus in on goal number 7, which was to ensure environmental sustainability. And this is where the WASH goals are buried. So within 7C, we have the goal of having the proportion of population without sustainable access to safe drinking water and basic sanitation by 2015. For water, the goal was to achieve 88% coverage, and for sanitation, 75% coverage globally. However, it is key to note there is absolutely no mention of hygiene in the MDGs. They also ended in 2015, so what's next? We've also discussed the SDGs briefly, and here we finally see that water and sanitation have been given their own goal, number 6, which is a huge step in the right direction. Some say that these goals collectively are too ambitious, and if we look specifically at the WASH goals themselves, we see that by 2030, the goal is to achieve universal and equitable access to safe and affordable drinking water, to achieve access to adequate and equitable sanitation and hygiene. Please note that finally hygiene is given a specific reference, but it is part of sanitation, and end open defecation, which is very important, as you'll see in the coming slides. And the rest of the sub-goals go into water quality, efficiency, and environmental management and stewardship. So in short, we're on our way, but let's see if this is actually feasible, these goals. Can we actually attain them by looking at what our current state of affairs is? Before we're able to do that, though, we first need to establish some terms. So you're going to hear me reference improved and unimproved water in the following slides. According to the Joint Monitoring Program, that initiative between UNICEF and WHO, an improved water source is one that, by the nature of its construction and when properly used, adequately protects the source from outside contamination, particularly fecal matter. So when looking at the following sources, we can determine that this is an improved source. What about this one? Also an improved source. This, unfortunately, is not an improved source because anybody, if they were to openly defecate near this source, rainwater comes, it's going to push that feces into this open well and contaminate the water. This one is slightly confusing, but this is what we call a protected spring. So it's a mountain spring coming down off the mountain. This is an improved source because they were able to build a catchment around that source to prevent contamination from the environment. And then finally, we have an open water source, which is clearly an unimproved source. So if we look at the latest of the data available from the JMP, we see that although 147 countries met the drinking water goals, least developed countries, primarily in Africa, did not meet the MDGs. Globally, we did meet the goal of 88% coverage in 2010, so we are on the right track in terms of water, but you will note that there was some limited or no progress, predominantly in sub-Saharan African countries. The good news is that from 1990 to 2015, 2.6 billion people gained access to improved water sources, and 91% of the global population now uses an improved source. It's only 3 countries that have less than 50% coverage, and these are Angola, Equatorial Guinea, and Papua New Guinea. The bad news is that 663 million people still remain without access to improved water sources, 90% of which live in rural areas. So the following table demonstrates the change from 1990 to 2015 in water access by WHO regions. Let's start by looking at the graph here on the right. What you'll see is that access to any improved water source in 1990 was 76%, and by 2015 we had climbed up to 91%, surpassing the MDG target. And now only 2% of the global population still remains without access and uses surface water like lakes, rivers, and streams as their primary source of drinking water. When we look at least developed regions, we can see that access has increased, but it still sits at about 69%. So there's still a lot of work to be done in least developed regions. And finally, I'd like to draw your attention to Oceania, where unfortunately access to piped up water on premise has decreased over the 15-year period. In sub-Saharan Africa, where access is still below 70%. They do remain behind the curve, so there's a lot of work to still be done in those 2 regions. Finally, as I previously mentioned, there are disparities in access to improved water between urban and rural communities. In fact, 8 out of 10 people without access to safe improved water live in a rural area. So you're probably wondering what these other improved sources are that you've been looking at in these slides. These include piped water that goes into yards, not directly into somebody's house, public taps, hand pumps or boreholes, protected wells, protected spring like the one I showed you in the previous picture, and rainwater catchment. So moving on to sanitation, we also need to define what improved and unimproved sanitation facilities are. So according to the JMP again, an improved sanitation facility is one that hygienically separates human excreta from human contact. So let's look at some examples. If we ask ourselves improved or unimproved, this is an unimproved facility because it's open to the air, flies can contaminate, people can contaminate. We see a couple of men openly defecating in a canal here, clearly an unimproved source of sanitation. This is technically an improved facility because the feces is separated from the environment, but what we would like to see to make this facility even better is a ventilation pipe coming up here that would actually help create a fly catch for the toilet. As you can see in this communal facility, there is the ventilation pipe, which plays an important role in improved sanitation. Now, this is a trick question because according to the JMP right now, communal or shared facilities are technically not improved facilities, and this is due to challenges of operation and maintenance, which I referenced at the beginning of my talk. They're now in the process of revising that because of the fact that this is actually an improved facility by definition. And then finally, we have improved facilities with ventilation pipes. This is the ideal rural facility. Okay, so how are we doing? Well, unfortunately, we missed the target for the sanitation MDGs by almost 700 million people. We only reached 68% coverage by 2015. And again, you can see that Africa has made the least progress, but let's unpack this data just a little bit further. So from 1990 to 2015, almost 2.1 billion people gained access to improved facilities. However, less than half the global population still uses an improved facility, leaving 2.4 million people without access to improved sanitation, and 946 million still practicing open defecation. 2/3 of those that still practice open defecation live in Southern Asia, India predominantly, and there's been a slight increase in open defecation in Sub-Saharan Africa over the 15-year period. Finally, the vast majority of those without improved facilities live in 3 regions: Africa, South Asia, and Oceania. Again, looking at our regional variations from 1990 to 2015, first focusing on the world, we can see that globally, access has increased from 59% to 77%. Least developed countries still lag well behind other regions, with only 45% having access to an improved or shared sanitation facility. We can, however, see that open defecation has declined in all regions, which is very encouraging. However, Southern Asia still has the highest burden of open defecation, with 34% of the population openly defecating. Again, this is predominantly due to the large population in India that does not have access. While Sub-Saharan Africa has made some progress, there's still some work to do, and unfortunately things have plateaued and are not making progress in Oceania. And finally, there is much greater disparities between urban and rural areas with regards to access to improved sanitation. While 82% of the urban population uses an improved facility compared to 51% in rural areas, despite a 73% increase in urban population over the same time period, while the growth in rural areas was only 11%. So clearly there's some challenges that we have to overcome in terms of achieving access and equity in rural areas. They're still going to make me sick, excuse me. Also, gray water becomes a vector for mosquito transmission, livestock, and then also water management. Because most water facilities are not at a household level, they require some level of group action and engagement. So why does all of this matter? Well, when most people think about wash diseases, they typically think of diarrhea. And while that is, of course, correct, there are a number of wash-related diseases. And these include those that are transmitted via the fecal-oral diseases. Those are viral, like hepatitis A and polio, bacterial, like cholera and typhoid, and also protozoal, like Giardia. There's also water-wash diseases, skin and eye infections like trachoma, or louse-borne diseases like relapsing fever. Other wash-related illnesses include intestinal parasites, what we call soil-transmitted helminths or hookworms. There's also tapeworms associated with poor wash behaviors. We also have water-based diseases. These are bacterial like cholera, because cholera thrives in water, or helminthic as well, like dracunculiasis or guinea worm, which I had the pleasure of working with in Ghana as a U.S. Peace Corps volunteer. Related to wash is the vector-borne diseases, because if we don't manage our gray water, then we can end up having breeding sites for mosquitoes, which then transmit malaria and dengue. Also, when we openly defecate, the flies that land on our feces can then transmit trachoma. And then finally, solid waste management, if we do it poorly, can lead to an increase in the number of rodents, which then can transmit diseases through our community. So there's a whole range of illnesses that are associated with water and sanitation and hygiene, but typically we think of diarrhea. And the most common route of transmission that WASH programs target is the fecal-oral route of transmission. This route is where feces enters the mouth through a number of different mechanisms. The easiest way to remember the fecal-oral route of transmission is to remember the 5 F's: fluids, fields, flies, fingers, and foods. So feces goes into fluids, which we then drink into our mouth. Feces also goes into our fields, which contaminates our food, which we eat. Feces is also landed on by flies, which then lands on our food, which we then eat. And then finally, when we use the bathroom, when we don't wash our hands well enough, we go and eat. It goes into our mouth, or we directly put our fingers into our mouth. So the goal of our program is to block these routes. And luckily, we know that if we provide people with safe water, we can prevent about 15% of diarrheal cases. If we only provide people with safe sanitation and block these routes, we can actually prevent 35% of diarrheal disease. If we just give people health promotion, just teach them about safe hygiene and safe sanitation, we can prevent 33% of diarrheal cases. But most importantly is hand washing with soap, blocking these final routes. Hand washing alone can prevent 47% of diarrheal cases. So this is the big news here. What we have most recently learned, though, is the role of chicken feces in the environment and diarrhea. In many low-income countries, chickens are allowed to roam free, pooping in and around households. So, with so much chicken feces in the environment, children easily touch the feces with their fingers, which then contaminates their food, or they put their fingers in their mouth, thus causing diarrhea. So one of the primary goals of our WASH programs is to block these 5 Fs of the fecal-oral route of transmission. But I do want to be clear that WASH does more than just prevent the transmission of diarrhea. In fact, if we look back at the MDGs, improved WASH directly and indirectly contributes to each of the 7 goals of the MDGs. So there's clear links between WASH and economic development, which we'll be looking at in just a moment. But the basic idea here is that if you're sick with diarrhea, you can't go to work. If you have limited access to water sources, and you have to make a cost-benefit assessment on how to use the resources that you have available to you. It also impacts our achievement of universal primary education. If you're sick, you can't go to school. If you've got intestinal parasites, you're likely to have decreased participation at schools. Also, girls don't go to school while they're menstruating, and we'll discuss these in more detail momentarily. Also impacts the promotion of gender equality and empowerment of women. Defecation practices in latrines become a safety issue for some women when using sanitation facilities. Also, women disproportionately carry the burden of WASH management, fetching water and storing water in the household. They also have limited involvement in many of the formal programs, so there's an opportunity here to engage women that sometimes is lost. Very clearly, there are links with under 5 morbidity and mortality, which we're going to explore in a moment. And also, there's a link with improving maternal health. Diarrhea, parasites, and others lead to a weakened immune system and anemia, which can cause birth complications. Also, there's a lot of evidence now that hand washing is key for health practitioners during delivery. We also need clean water to take our HIV meds. If we're giving people dirty water, then unfortunately we're putting their immune system in a compromised situation. Also, as I've already demonstrated, there's a direct link between poor water management and vector-borne diseases like malaria. And we already know the direct link between Goal 7, which is where the WASH goals live. So let's look at some of these issues in a little bit more detail. Every year, 9.2 million children die before their 5th birthday. And what are the global causes of death? Well, pneumonia and diarrhea are the number 1 and number 2 causes of under 5 mortality. Undernutrition is implicated in more than a third of all under 5 mortality. And neonatal mortality, which is death within the first month of age, is a large share of the total under 5 mortality. Includes preterm birth, birth asphyxia, and severe neonatal infections. So what do we know? Well, we know that diarrheal disease is one of the biggest killers of children and is directly related to WASH. 88% of diarrheal deaths are associated with poor WASH. We also know that pneumonia is an enormous contributor to under 5 mortality. And we now have evidence that there is direct links between hand washing with soap and the reduction of acute respiratory infections by up to 23%. The only rigorous study conducted in the developing world in Pakistan showed a 50% reduction in the incidence of pneumonia with hand washing. Very, very exciting news. A recent study conducted in Nepal also showed that maternal hand washing with soap can reduce neonatal mortality by 45%, and hand washing by birth assistance can result in a 19% drop in neonatal mortality. And finally, undernutrition is implicated in 35% of deaths, and in a few slides we'll see the link between undernutrition and under 5 mortality. So let's quickly look at the relationship between sanitation and under 5 mortality. This is a plot from a paper published in 2008. So yes, it's a little bit old, but the data it presents still holds true today, showing the individual countries' sanitation coverage on the x-axis and their under 5 mortality rates on the y-axis. Countries in red are in sub-Saharan Africa. So what do we see? Well, there's almost a linear relationship between sanitation coverage and under 5 mortality, where the lower the coverage, the higher the under 5 mortality rates. If you have a moment, I would encourage you to follow this link to the Gapminder website, where this relationship between sanitation coverage and under 5 mortality is presented more clearly over time using 4 countries as an example. Welcome back. I hope you enjoyed that. If you want, you can explore more data manipulation with the Gapminder website. But let's look a little bit more deeply now at this relationship between WASH and health. And so we know that 2.4 million deaths, preventable deaths, and 6.6% of the global burden of disease are due to preventable WASH. We also now can see the relationship between nutrition and malnutrition. 7% of WASH disease is directly associated with malnutrition, and reductions in diarrhea can also reduce the incidence of disease that results from malnutrition and account for 29% of disease burden. We know that frequent diarrhea and parasite infections contribute to malnutrition, which then contributes to susceptibility to other illnesses. And now we know about tropical enteropathy and the relationship between tropical enteropathy and the access to improved sanitation, where we look at Z-scores for those with and without sanitation. So basically what this does is a subclinical condition due to frequent intestinal infections and diarrheal bouts that then creates an issue with malabsorption and malnutrition and stunting. Okay, so that seems clear. There is a direct relationship between WASH and health, but there's also a relationship with WASH and economics. As this slide presents, the global impact of poor sanitation on economics is enormous, estimated at greater than $260 million per year, which is greater than Chile's entire GDP. East and South Asia carries the majority of this economic burden, followed by Latin America and the Caribbean and Sub-Saharan Africa. The World Bank estimates that poor sanitation costs countries 1.5% of their annual GDP, which is no drop in the bucket, or $54 billion in India, which the World Bank estimates as the entire GDP of Croatia. Finally, researchers have also demonstrated that GDP growth is impacted by poor sanitation. But how, you might be asking, does poor sanitation influence our economies? Well, using Kenya as a case study, we see that $324 million is lost annually to poor sanitation, and this loss is attributable to 4 main areas: premature death, healthcare expenses, productivity losses, and access time. So as people die prematurely, as the healthcare system expends more resources on easily preventable illnesses, as individuals are absent from work or school, and last but not least, as people seek locations to poop, all of this impacts a country's economy. And finally, looking at the same issue but from a slightly different perspective, economists have calculated that every dollar spent on WASH has a return of between $5 and $46. In addition, WASH disease prevention could save an estimated $7 billion per year on health system costs. These are no small numbers, especially considering the investment in WASH can be minimal for an enormous return. Directly related to the impact of WASH on the economy, as referenced before, is the impact of poor WASH on the achievement of primary education. An estimated 443 million school days are lost annually due to WASH issues, including 272 million directly due to preventable diarrhea. Parasitic infections have been shown to contribute to the loss of 633 million IQ points due to anemia and other issues. There's also a relationship between impaired physical and cognitive function due to repeated insults of diarrhea, which, as we've already discussed, contributes to malabsorption and malnutrition. Less recognized due to the sensitive nature of the topic is the high rates of absenteeism in menstruating girls. Because sanitation facilities at schools are non-existent or poorly designed, many girls choose to stay at home during their menses. This includes a lack of facilities to dispose of sanitary napkins and water to clean oneself afterwards. Not only this, but women and girls are also affected by violence and rape due to lack of sanitation facilities or the siting of those facilities. Many young schoolgirls are approached inappropriately during school hours because the facilities are located so far away from the school blocks. Many women also choose to defecate at night due to the social stigma, which increases the likelihood of violence and rape. Finally, as it's well established, girls disproportionately carry the wash burden as they are responsible for fetching and storing water, managing water at home, cleaning the household, ensuring the family is hygienic, preparing food and cleaning dishes, washing clothes, and the list goes on and on and on. Because of this burden, many girls are unable to attend school or miss portions of school. In some cases, girls are responsible for the collection of water at school too, taking them out of the classroom while the boys stay behind to learn. In recent years, there's been a heavy emphasis on understanding the role of wash in school. We now know that hand washing and the provision of treated water at schools can reduce absenteeism, and that this effect is even greater for girls than for boys. This is important because we also know that for every 10% increase in female literacy, we can expect a 0.3% increase in economic growth. And this impact is not reserved for the students alone, as the provision of wash facilities also reduces absentee rates in teachers, thereby improving the overall educational system. Okay, so now we know that what the problems are around wash and how wash not only affects health, but also general development. So what have the solutions been to address this problem? Well, in the first half of the 20th century, the principal model was one of donor and NGO-driven service provision, where external agents would identify low-access areas and simply provide the necessary infrastructure. They would drill boreholes and build latrines, but typically these weren't integrated or coordinated at a national level. Hygiene education, if provided, was secondary and followed didactic teaching methods. This approach contributed to what we call wounded soldiers, which you can see a picture of in this slide. This is simply just a leftover toilet that somebody used maybe for a little while, but then was left as a standing symbol of the ineptitude of the programs up until that point. Because communities were not engaged in the process and the services were provided as a gift, most did not respect these facilities, or when they broke, they discontinued using them. They didn't have ownership over these facilities, so they didn't reinvest in them once they were not working. So in the second half of the century, we shifted to participatory models and self-supply schemes. So now communities were supposedly at the center of all planning, with leaders engaged from the beginning and water and sanitation committees established and trained. Water and sanitation remained separate and behavior change was still not prioritized. We felt that if you just engaged people in the process, then that would resolve the issues mentioned previously. But alas, the same results followed. However, there were some strong successes that began to emerge at this time, which I will begin to discuss in just a moment. Governments typically were still not involved, although most governments decentralized at this time, giving up power and management of wash programs to their municipalities and their districts. Then finally, as we entered into the 21st century, some truly innovative approaches began to emerge, using social entrepreneurialism and lessons from the business world. Instead of providing for people, businesses were created that would market to and provide services for the populations that were determined at need. Many of these models are proving successful, but there are, of course, holdouts using the old models, and they believe that you should not make people pay for what the UN has deemed as a human right. Where do you stand on this issue? So looking specifically at water programs and interventions, our goal is principally to provide improved services and/or infrastructure. So this includes the drilling of boreholes, the protection of wells, the establishment of water systems, and the creation of businesses to sell water. It clearly depends upon the country and the context. Many rural schemes are still focused on self-supply and management, where in collaboration with NGOs or government, communities gain access to a water source and are then trained to operate and manage that facility. However, in high-density urban settlements, enterprise-driven models have begun to prove effective. There are a number of examples of this model, including those developed by the NGO Water for People. I would encourage you to visit their website if you're interested in learning more about these social entrepreneurial models. In addition to the provision of infrastructure, water programs also include point-of-use water treatment. So when people bring their water back home, they're encouraged to treat that water to ensure that it's purified. These programs include filters like the blue biosand filter picture here, and chlorine like the Gaden Glow organization in Haiti that sells chlorine dilute solution to households. There are other systems as well, including those that use solar disinfection. When we look at sanitation, the approaches are pretty similar to those associated with water. Again, context is everything. As to what works in rural settings does not necessarily translate well to urban settings. Much of the programs in rural areas again focus on externally driven or self-supply initiatives. Households are encouraged with and without subsidy to build their own latrines. There's usually some degree of health promotion and community mobilization around sanitation, as there is a latent demand for sanitation. But because people have been openly defecating for years, they don't necessarily see the utility of buying and building a latrine. To address this, the community-led total sanitation model was launched in the late 1990s in Bangladesh. This model uses fear and disgust to motivate people to build their own latrines. If you look at the picture here, this is a triggering agent who has put some fecal matter inside of this drinking water and is asking people if they would like to drink it. This is the way of triggering a community to say, oh my God, that's disgusting, we don't want to do it, and motivating them to build their own toilets. So while this model has been effective in Southeast Asia, it has not yet demonstrated long-term success in Africa and other regions. Just like with water, social enterprises have also become effective methods of addressing sanitation in urban and rural areas. Using social marketing techniques, WaterAid and UNICEF have demonstrated the power of the market in Southeast Asia and Africa to address sanitation. And then finally, looking at hygiene education and behavior change. Unfortunately, this is still considered an afterthought by many programs, but behavior change is finally starting to receive its due. Many programs still rely upon traditional participatory health and sanitation transformation programs. This is the model of participatory education developed in the 1980s that uses trained facilitators and drawings to stimulate discussion in community settings around major WASH issues. The idea is to give people education using the health belief model that will then stimulate behavioral change. However, because it is limited in scope, it's only really been shown effective at increasing knowledge. It has been less robust at achieving actual behavioral changes. Another model that has been much more successful in demonstrating behavior change is the community health club model, and this is the model that I work with and which I will be discussing in more detail in our class meeting. There are other approaches, including social marketing, that emphasize disgust and status to achieve behavioral change, especially with relation to hand washing with soap, as well as mass media campaigns. Each has varying degrees of success, but the key here is that we have learned a lot about behavioral predictors over the course of the last 20 years, and we are finally using that knowledge along with theory to design targeted programs that are finally gaining traction and changing people's behavior. I do give an entire lecture on community health clubs and on behavior change, so I'll spare you the rest of that information now. So to conclude, just as with any sector and issue, there are a number of issues and challenges that must be addressed and overcome. One of the issues is continued stovepiping, and what I mean by this is water is considered separate from sanitation, is considered separate from hygiene, education, and behavior change. For us to be effective, I believe that we need integrated models that address all three components simultaneously, because you can't address one without addressing the other. In addition, some people think that the only solution is technical solutions, like the Gates Foundation, who is now recently engaged in the Reinvent the Toilet campaign, spending billions of dollars on innovative solutions to latrine design that in some people's opinion is a complete waste of resources. Or is the real focus on behavioral changes? Do we need to change the norms and values of society so that they want toilets and water? There's many different ways that one can view this. There's also an issue of competing funding priorities and a lack of advocacy within the water, sanitation, and hygiene community. Most people tend to focus on disease-specific outcomes, HIV, malaria, tuberculosis, whereas WASH is a cross-cutting issue just like gender, so it's hard to find actual grants and programs that will focus just on this. There's also this question of, where does WASH belong? Is WASH its own sector? Should it fall under health? Is it a maternal and child health issue? Is it a development issue completely separate from health? And because of this, some people can have difficulty conceptualizing where we should focus our energies. There's clearly an issue between urban and rural communities, and the solutions for one are not easily adaptable to the different setting. Some people are experts in urban areas, some people are experts in rural. This causes challenges. One of the issues also is that typically governments just do not buy in and invest in water and sanitation services, relying upon the international community to provide these programs. And because of that, there's issues of sustainability. If external donors are providing these programs, then what's going to happen when the system fails? If people are providing it for themselves through self-supply or entrepreneurial programs, then we believe that the opportunity for success is much greater. And finally, we're still working on getting private sector involvement more robustly, but we are making headway in this area. So I want to thank you very much for your time today, and I look forward to discussing this issue in more detail in our class session.